Give it a few more minutes, let a few more people sign on. I think we're in the session. Amy, can you just enter in the chat? Are we in the live session now? Okay, all good to go. All right, I think people will continue to sign on, but I'm gonna go ahead and introduce you, Dr. Emezue. Hi, everybody. It's my pleasure today to introduce one of our very own. And this is Dr. Chuka Emezue. And just a word of warning, he's on daddy duty at home with an 18-month sleeping upstairs. So he's kind enough to do two things at once. I'm going to read from this paper because his CV is so dense. I'm going to get lost in it. So welcome, Dr. Emezue. Dr. Emezue is an assistant professor at the Department of Women, Children, and Family Nursing here at Rush College of Nursing. He earned a PhD in nursing, a Master of Public Health, and a Master of Public Affairs from the University of Missouri, Columbia. His research program utilizes community-engaged approaches to develop, pilot, test, and deploy technology-enhanced interventions that address co-occurring interpersonal violence, mental health, comorbidities, and substance use with at-risk populations in humanitarian justice-involved immigrant, Black, and Latinx Hispanic contexts, which is part of what he's going to talk to us today about. Over the past 5 years, he has developed and is pilot testing 2 culturally congruent and technology-enhanced interventions. Brotherly Act is a web and mobile compatible intervention for violence and early substance use prevention among young Black males using life skills coaching, safety planning tools, and an AI-facilitated chatbot. While Fatherly Act is a trauma-informed father-son dyadic in-person and online program to improve the safety and well-being of mothers and children exposed to intimate partner violence by enhancing healthy father-child connections, lessening the devastating impact violence by enhancing father-child connections, lessening the devastating impact of partner violence on mothers and children. He is a 2023 Public Voices Fellow with the Op-Ed Project, RBIHE Health Equity Scholar, and Cone Fellow. He has been a contributor in residence with the Synapsis Medical Humanities Journal, and his op-eds have appeared in Board Panda, Ms. Magazine, and Cleverish Magazine. So we'll be here till next grand rounds if I continue. So that's what I have to say. I'm going to mute myself and let's begin. And I'll monitor the chat for you, and we can take some questions at the end if time allows. Thanks for joining us.
Of course. Thank you so much, Dr. Bash, and I do apologize. That is a long intro that I will now trim down. But welcome everyone to this ground rounds. Hopefully you can hear me clearly and you can see the slides. Reaching you from home today. I am in what is, 50% of jungle and 50% my home office, hence the plants in the background. And my 18-month-old is sleeping soundly. And I hope he stays that way for the next hour. Today I'm going to be talking about violence and substance use prevention amongst young Black boys and men. And I'm also going to be talking about how we have used, or we're currently using technology-enhanced intervention to address both issues with this population. I have no disclosures or conflicts to disclose financial or otherwise. I'm going to skip this slide. These are our learning objectives for today. And I'm going to paint a picture. We'll look at this from a 30,000 feet view nationally across the US, and then I'll bring it home to Chicago specifically. When we talk about pediatric and youth violence in general, I like to paint a picture of what that is, what exactly this topic is about. And so it involves every act of physical, emotional, and psychological violence or abuse that involves children and adolescents, which is the population I work with. This encompasses everything from bullying all the way to relationship violence. I often put these slides when I talk about this because I think this is a very clear and simple representation of how big of a problem violence is and substance use is in the lives of our youth and children across America. Now, the first panel shows a trend upwards right around the pandemic in firearm-related deaths among children and adolescents in the US. This data stopped in 2021. The second panel shows this broken down by gender. Unfortunately, most of the data I will show today, as reflected in the, most of our data sets, collect binary gender, so male and female only. The firearm-related homicides is the third leading cause of death. U.S. youths are right up there in terms of their exposure to this form of violence, which, in a way, you can describe it as the most extreme or one of the most extreme forms of violence that a child or adolescent can be exposed to. But, when we look at young Black males or Black youth in general, we start to get a little bit of a nuance in how this is broken down. If you look at the chart, this is broken down by race and ethnicity. So firearm-related deaths for children and adolescents between 2018 and 2021. Right in the middle, you'd see the prevalence rates for Black youth. And in 2021, there's a trend upwards, a very big spike in 2021 during the pandemic for this population as well. And when we bring it down to boys, Black boys and men, this is the worst affected group of youth that are exposed to firearm-related homicides. About 24 times more likely to die from firearm-related homicides. And I want to make a distinction between firearm mortality and firearm homicides. So in terms of mortality, we're talking about all-cause mortality. So everything that involves intentional homicide, as well as unintentional homicide, like suicide by firearm, accidental discharge, and the likes. So firearm mortality rate for this group is 4.3 times higher compared to white youth. In terms of their firearm homicide rates, it is also 14 times higher compared to white youth specifically. There's also the long arm of trauma. We found that, and study shows that 50% of young Black males who survive a penetrative injury will return to the hospital for a similar injury within 5 years, and about 20% of that population will pass on account of firearm violence. This is a chart that I love. It's quite dated. It's from 2018. There's no more recent data, but this is from the CDC, and it captures the leading causes of death for males in general across the lifespan. And you find that for those between age 0 and 44, the homicide represents the #1 leading cause, period. When you look at all ages, homicide is still there in the top 5. So I'm looking at the very last column in this case. Homicide rates and suicide rates we found also are trending alongside each other, although there's a bigger spike in terms of homicide rates, but firearm related suicide rates are also spiking alongside that. That's basically what this chart is showing. This is data from the CDC and Johns Hopkins School of Public Health as well. I want to bring us also to substance use, which is another topic that you will find co-occurs quite often with violence. I want to make a distinction here too as well, that substance use doesn't always and often lead to violence perpetration, and not all forms of violence are, linked to past substance use. But annually, we find that about 700,000 emergency department visits by urban youth are for assault-related injuries. About 20% of that is linked to substance use as recent as the 3 hours preceding that injury. We find also that substance use plays a key role in about 40 to 60% of partner violence incidents as well. And when we look at the chart, let's skip to the figure 2 on your right, you see a distribution of drug overdose deaths among adolescents by race and ethnicity. Now, when you look closely at this figure, you would see that white youth have a higher percentage rate for drug overdose deaths. But when you look subsequently at the following bars, you see that while there's a downward trend in overdose deaths among white adolescents, there's an uptick for Black, Hispanic, and Asian youth, as well as American Indian youth as well. And so various risk factors sort of marry violence and substance use. You'd find that the risk factors for both comorbidities sort of overlap. This is a schematic that captures some of this. This was adapted from the World Health Organization, breaking this down across various socio-ecological levels. I wouldn't dwell so much on this slide, but I wanted to show us how vast the scope of effects are for violence that affects our children and our adolescents. The solid circles show a direct effect related to violence against children, and then the white circles on the margins show an indirect effect. So simply put, violence impacts various aspects of their health and well-being, their physical, psychosomatic, and mental health in general, and also has long-term consequences that follows them across the lifespan. So we're looking at chronic diseases here as an indirect, and in some cases, a direct link to violence exposure. I often talk about being on both ends of the gun, not to sensationalize the topic of gun violence, but to show that most of the young men we work with and most of the young men who are impacted by this issue often occupy this triadic status, where they are both the victim, the offender or perpetrator, if you will, as well as the witness of violence. I will show you somewhere about 70-something% of our population here in Chicago, for the young men we've spoken to, occupy these three conjoined statuses as well. So think about the trauma cumulative effects from occupying this various position of both victim, offender, and witness. So what are the patterns and strategies utilized by racial and ethnic minority youth when seeking supportive services? We've clarified in this case what some of the, the problems are, but I want to give context, with more recent data and studies that we've analyzed ourselves. So what we did was we looked at the CDC data set. This was a one-time survey. It was done in 2021. The Adolescent and Behavioral Experiences Survey, or the ABES survey. And what they did was they sampled about 8,000 high schoolers across the US. What we did was we excerpted racial and ethnic minority youth from that general sample. We wanted to see what their substance use and violence experiences looked like, but we also wanted to see what their help-seeking strategies were with relation to seeking help online. This is a breakdown for our statistics wonks. Here, this just shows, our methodology, but I want you to pay attention to the very last column, looking at some of the outcomes we wanted to sample and analyze specifically. So we looked at victimization, we looked at perpetration. We also looked at family violence, which you will find in with the surveillance data spiked during the pandemic as children and adolescents were locked indoors at home. We looked at substance use, and our dependent variable, if you will, was looking at their telehealth use for mental health support, having experienced all of these things. The table, pardon the tiny font, Well, basically, the summary of what you're looking at right here is we did not find a statistically significant association between age and telehealth use. We also did not find that for sex. Unfortunately, in this case, the CDC only collected binary sex, male and female. We didn't find any differences in terms of ethnicity. However, we found statistical differences in terms of their race and their sexual identity. I'm going to show you how this data breaks out in the next slide. So there's a lot going on my slides. I realized that, and so I try to summarize as best as I can. We found that there was a statistically significant association between substance use and seeking out or using telehealth support for mental health. We found the same link for experiencing both peer, so in this case, youth violence and family violence, and telehealth use. Interestingly, we found that high schoolers who reported carrying a gun showed a higher likelihood of using telehealth for mental health, about 4.8 times higher likelihood. Students who were engaged in a physical fight who carried a weapon, in this case, gun, knife, or club. Those were the specific weapons that were analyzed in the data. I'm not quite sure why. The same thing also occurred for illicit drug use, showing clearly that racial and ethnic minority youth started to turn to telehealth for supportive care during this time. In general, we found, if you look at panel A, it shows the highest used group being multiracial. A disclaimer here, multiracial, if you look closely at the data, sort of captures various things. Specifically, we have people identified by multiple races and ethnicity as a personal preference. And so the CDC data captured them that way. This study has been submitted as currently under review at this point. That sort of set a case for, if this is happening at the national level, wanted to see what's going on in Chicago specifically. And so being that young Black boys are what's affected, we sampled that group specifically. What we've done over the past 2 years was we started out with needs assessment phase of our research. In this case, one of the things we did was a cross-sectional study. We recruited about 266. I should say that number has gone close to a little bit over 300 young Black males. At this point, I should update the slides. But those aged 15 to 24, we recruited them from the west side and the south sides of Chicago. The mean age for this group was, a little over 18. Most of them were Black, 99% of that population, about 8.8% identified as Hispanic or Latinx. The highest education was some high school. We also looked at their dating history because we also were looking at their use or experiences of partner violence as well. Most of them identified as single, most of them as students, and there was a high smartphone ownership. Being that we are, slowly taking you all towards technology-based intervention here. But I want to also say that in terms of their internet use, even though smartphone ownership was high, internet access was not that high as well. We did not collect that data, but typically that's how the data presents. About 54.2% of them reported being impacted by various forms of violence, from physical fights to gang-related violence. In terms of the most occurring form of violence, physical fighting in school was the most occurring. About 66% of them had been in at least one fight in the past year. In terms of their dating and relationship violence, 30% of them reported perpetrating partner violence. This was broken down into psychological abuse at 40%. And physical abuse at 32%. We also wanted to look at risky firearm behaviors. We wanted to look at their weapon carrying, weapon use, and the likes. We looked at the 30-day gun or weapon carrying, and we found that almost 20% of them reported carrying a gun or a weapon 2 to 3 times in the past month. So this is at least 6 times higher than what the national average is for a recently published study. About 20%, in this case, 19% of them talked about reported threatening someone with a weapon in the past year on 2 to 3 days. And this is that number for those who occupy that triadic position of having witnessed, experienced, or perpetrated violence. 73% of them fell into that category. The substance use profile, and I'm sure this is not news to us, but we also found, high incidences, prevalence rates with this group too as well. In short, binge drinking, which, we're talking about young males here. So that is above 5 drinks in one sitting or in one event in the past 30 days. About 20% reported binge drinking. We found that some, 40.2% of them had reported using some form of medication that was not prescribed for them, and about that same number used, some kind of substance while or during or before perpetrating violence. So now that we've looked at the problems, I sort of divide my speech into the problems, and now we're just going to be focusing on the solutions. This is our best case scenario, what the CDC has published, having done a meta synthesis of what works out there, and they've broken this down into strategies. And what we did was we honed in on 2 specific strategies. So strengthening youth skills as a way to reduce their use of violence and substance use. And we also wanted to intervene to lessen the harms and prevent future risk. And so that's why we have this wide age margin from 15 to 24. We have done this using research and various other strategies. I'm opposed to, partnering with youth, doing a research study with them and handing them a gift card and sending them on their way. We've found that doesn't work. Our community partners have advised against this format. And so what we've done is we've combined our research with various strategies. In my lab, we have a youth advisory board. They just started with us a few weeks ago, and they are advising both the research, the interventions, and areas that we haven't even thought about or considered. We organized a boot camp here at Rush in September. We had 28 high schoolers join that boot camp. It was focused on leadership, entrepreneurship, and technology-based skill. This was not a research study. We didn't collect any data. And so we have planned a creative writing contest. In general, trying to engage these young people as best as we can while building and harnessing both their economic prospects, their personal prospects, and their mental health in general. Our community partners have been involved as much as we can using a CBPR lens. So they've informed, our compensation, our recruitment materials, our survey questions, and making sure that it rightfully reflects the lived experiences of these young people. If you haven't noticed, our focus is a strengths-based approach. The young people, in our qualitative studies, know that the violence is bad. The young men tell us they know it's bad. They know the substance use is bad. But what next? And the what next is, what are we specifically trying to do to address these issues besides, didactic psychoeducational interventions? And so what we decided to do was to develop technology-based intervention. This idea came up during the pandemic. We wanted to augment, not supplement or not replace existing violence and substance use prevention programs. And since a lot of us hang out on our phones anyways, we wanted to see if it was possible to develop this intervention as an app-based intervention that is trauma-focused and culturally congruent. The goal, in short, was to deliver life skills training to these young men and to connect them to vetted and trusted community resources. It's all of this was structured as a 3-phase study. We're currently between phase 2 and 3. Phase 1 was everything I talked about, needs assessment. I'll show you what some of that process looked like. Phase 2 is our usability testing, an adaptation of what we've designed as an app with these young people. In phase 3, we will do a clinical trial early next year in January of 2024 with samples of young Black males who are reporting for injuries or firearm-related injuries across 3 emergency departments here at Rush, UI Health, and at Stroger, Cook County. In terms of our phase 1, phase 2 findings, I'm not going to dwell so much on this. This may not surprise some of us. You know, this young men, many of them have been born into this life. Many of them have seen family members go down, experience death and loss, incarceration, and the likes on account of violence. What we did was we spoke to 55 young Black males aged 15 to 24 to understand their violence experiences and sort of figure out what their needs were in terms of addressing violence and substance use. They had both positive and negative perceptions of existing programs. There was a high level of service avoidance and emotional avoidance with this population. They are distrustful of researchers, distrustful of healthcare providers and legal actors as well, which is not a surprise. They describe some of the benefits of violence. It sounds like a conundrum or a paradox, but in this case, for some of them, violence was the difference between life and death. They couldn't get on a bus, they cannot get on a train to go seek out supportive services in a brick and mortar facility. And so they, they had grown to cope using various maladaptive strategies. There seemed to be a need for equity-focused services. There's a high percentage of our population that have that report the need for felon-friendly services, as many of them cannot get traditional jobs, having had a felony record. This is an excerpt of what some of them are saying. I'm going to move from this slide pretty quickly. It's a lot to read. It basically talks about, just contextualizes some of their experiences with violence and growing up in Chicago. Taking all of this and putting it all together, we developed Brotherly Act, and to make it a brief intervention, they have explicitly told us they do not want an intervention that reminds them of school. It's a skill and solution focused intervention, youth endorsed. We're very, very interested in maintaining their safety and privacy, having been burned in the past with some of the programs they had used. And I'll show you specifically, how we have done that and what that looks like. But before we get there, this figure looks like a spaceship or something. Basically, it's a schematic that shows the various components of the Brotherly Act app. The ACT in the name is derived from the acceptance and commitment therapy, and that is the therapeutic foundation of this intervention. Brotherly Act combines micro-learning psychoeducational modules, and what that looks like is we have 7 modules that they can complete within 5 to 7 minutes, complete a quiz to test their skills, knowledge, and practice and rehearsal of skills they had learned in the module, and then they move on to the next module. In the bottom, the square, the light green or lemon green box, we have a set of safety planning tools. We have goal setting tools, mindfulness-based stress reduction tools, so things like square breathing. I'll show you screenshots of the app. I promise I'm not just going to talk about it. We have a mood tracking component and a risk assessment component. The final part is the dark green circle. That's the part we're still trying to figure out. The goal was to develop a service engagement AI-powered chatbot or a conversational agent that takes them outside of the app to connect them to community services that we will vet within a 50-mile radius. They can put in their zip code and it takes them to specific services. We're currently vetting those services. We're calling them and we're clicking website links to figure out what they're about before we include them as resources on the app. And of course, we're using the ACT-based principles, mainly with designing the psychoeducational modules. So we have modules, for example, focusing on drug and gang refusal skills. We have a module focused on adaptive coping and a module focused on mindfulness. I think I had a list of modules somewhere, maybe not. What we did with the acceptance and commitment therapy, for those of us who are theory wonks, was we adapted ACT and a different intervention that was designed and showed efficacy with adult men and women who are in incarceration for domestic violence. And so the adaptation that we did was one where, you know, adapting this intervention for youth violence. We were also adapting it for a different age group, in this case, 15 to 24-year-olds. And finally, we were adapting it for digital delivery. So naturally, this process has taken quite some time. I'm working with a colleague of mine who developed the intervention we're adapting. She works at the Iowa State University. And various effectiveness trials have shown that intervention does reduce criminal recidivism and violence recidivism. So the Achieving Change Through Values-Based Behavior is the name of the intervention. It's now being adopted across the Iowa Department of Corrections in general. It's a 24-week manualized program, typically conducted by a trained, 1 or 2 trained facilitators in a group setting. It has been tested and retested across various research groups, and it still holds up. Some of the positives of this intervention is they found effects for those who dropped out of the program. We're not quite sure what that looks like since the sample was incarcerated. So, attention or attrition was low. Survival analysis showed that the effects were sustained up to 5 years, not all effects, but some effects, which is a very big deal in the violence prevention world if you've been keeping track. Emotional avoidance and psychological flexibility were the 2 constructs that this acceptance and commitment therapy tries to address. Want to reduce the emotional avoidance and increase or improve psychological flexibility to make this, young men receptive to intervention. And so screenshots of the app, I'm going to walk you through some of the modules and select screenshots. What you're looking at right now in the green box is a list of the 7 modules. I knew I had that somewhere in there. And then the middle panel is the coping specific panel. They can swipe through the module and complete the quiz and move on. Kevin Durant is not part of our research team. I wish he was. But in this case, the orange button at the bottom, if they click that, is a quick exit button, takes them to the ESPN homepage. We can program that to take them to a weather app or a weather website. In this case, we also have PIN codes. The user needs a PIN code to sign into the app. If they try it twice and the PIN code doesn't go through, the app will dump whatever data that it has collected on them as a safety feature. This is what the risk assessment component looks like. In this case, we're looking at someone assessing their risk for gun violence. And we're using a personalized normative feedback approach. They can use the sliding bar to put their input, and this tool provides a risk score. In this case, 80% higher risk for exposure to gun violence. And when this risk score populates, we can either bounce them back to a module focused on gun violence or push them forward to the chatbot that connects them to specific resources. We also have a mood tracking component to the app. Emotional regulation is an effective strategy, a behavior change technique that we have found works with this population and for violence. And so what this looks like is emojis. I'll come back to you and let you know how this fared in our usability testing. But emojis, they get a push notification once or twice a day, and they can record their mood and why their mood is that way using the sliding bars. And then we can trend their mood over 30 days. And also, send them recommendations based on how their mood is trending. I talked about the zip code-based service connection. Right now, it's programmed to do a 50-mile radius within Chicago. In the future, we could expand that. Basically, connect them to various services. So everything from legal support, parent, child support, medical services, mental health services, and the likes. And I talked about the goal setting feature. This is what it looks like. In summary, they can track they can set and track 3 major goals using sub goals and giving themselves a timeline to accomplish those goals. And this is all based on the SMART goals approach. What this would look like in terms of holding them accountable to goal accomplishment, I don't honestly know. We cannot collect, for example, biomarkers to see if they've reduced substance use and those kind of things. But this is something that we'll try to figure out in the future for specific trials. And the last panel just shows some of the mindfulness component. A little bit of gamification is going on there. We've had parents ask for content for younger youth, age 11, 12, and 13. We don't have that group in our sample just yet, but this is something we're thinking about closely. We're going to try to, we've had requests to, take away some of the reading and make this a little bit more interactive. So using comics. We've also had requests to make this podcast style intervention for the modules so they can listen on their headphones while on the bus or wherever. And so that's something planned for the future. Speaking of the future, we recently submitted an R1 grant to the NIMHD. And in this case, we will do a randomized control trial using a wait list as control with 300 assault injured young Black males age 15 to 24 recruited from UI Health, Brush Emergency Department, and Cook County Emergency Department. And in this case, we're focusing exclusively on those who are reporting assault-related injuries. Our outcomes here are looking at perpetration reduction, victimization reduction, risky firearm behaviors, and psychological distress, which in this case is a catch-all for various mental health comorbidities. So there are limitations with, both our approach and the current approach. I've talked a little bit about the drawbacks of technology, which, we're familiar with. Anytime you talk about a chatbot, the hair on the back of some people's neck just goes up, including myself. And you're wondering, we're wondering about privacy concerns. There is no filter, when you have a large language model. There is no way to parse through that data. We don't have the manpower or the capacity to clean up that data. So we'll make it a very limited, closed network type of database. What that looks like is the youth will get repetitive information sometimes, which can, affect engagement. But this is something we're still trying out, and maybe in the future I'll let you know how that goes. But structural racism and neighborhood disadvantage are some of those mechanisms that are pushing the service avoidance and talked about earlier and the emotional avoidance. Mainly, we have young men who are dealing with multi-form violence and trauma, or using multiple substances, and who just need some kind of help to get out of all of that. Like I said, they understand clearly that the violence and substance use is bad, but they're looking for support, like gainful employment is one of the things they've asked for. They've asked for mentoring relationships, specifically with men who understand their background. But in terms of our current approaches, some of the deficits are, we have this colorblind approach to care and therapy. The acceptance and commitment therapy is one of those that, although transdiagnostic, is not often used with or developed for youth of color. There are also issues with program cost and benefits. Some of the wonderful programs we have here in Chicago, actually these programs have gone national, are the Becoming a Man program. And although the cost benefit analysis looks really good, so every dollar invested, there's a 30% gain, the program cost, absolute cost per participant, is quite high. The same thing for Working on Womanhood, another wonderful program. And so basically, we need to figure out ways to reduce program cost while making them effective. In this case, it would appear that technology can help scale some of the programs that we have found effective, which is what we're trying to do with Brotherly Act. The evidence in terms of the mechanism of action of interventions like ACT and CBT for aggressive youth is still not very clear. In this case, since we're addressing both substance use and violence, I had a chart to show our mechanism of action, hypothesized in this case, but we still need more evidence to clarify what exactly is going on and what exactly is changing. I want to give some room for questions, and so I'm going to skip some of my slides. I'm going to skip this one in terms of policy implication, and instead alluded to some of this dedicated funding, nothing for these young people without having them at the table, informing how research is done and how interventions are developed. In this case, this is not news to us. I'm sure we're very familiar with it. Our youth advisory board that started with us a while ago, one of the things they harped on in our very first meeting was the fact that adults do not seem to understand their needs and their problems. And I get it, I'm a little bit older, compared to them. And the way and the lens in which I used to approach this research is quite different from them. We need to reach, quote unquote, the hard to reach groups. I told you that they requested for felon-friendly services. We do acknowledge, or I do acknowledge, that most of our youth that we've worked with come from a school-based setting. And so we've not effectively addressed or reached out to the youth who are out of school, the youth who are unstably housed or homeless. I love this slide. I could just put this up, just this slide, and talk about some of the programs that we've done. This is Rush. If you can recognize the room in there. We had this young man. We started out recruiting just young men for the boot camp, and then we had people, parents, wondering what about services for the young ladies. We opened it up quite late, and so we had about 2 or 3 young women in the room, but they were mostly young Black males. Some of them are from Chicago Hope Academy, which is a wonderful partner of ours, as well as the Crane High School. Both of them are on the west side, so if anybody knows of a school in the south side that we could partner with, that would be wonderful. I want to wrap this up by acknowledging, my research team, the participants, and various other people. This is my village. It takes a village to do this work, and all of the support we have gotten in terms of our funders, Chicago Chronic Condition Equity Network, ITM, the Rush BMO Institute of Health Equity, and recently the Cohen Family Foundation, the Cohen Fellowship here at Rush. On the right are some of our wonderful community partners who have helped give us access to their populations. I can talk, in terms, if anybody's interested, in terms of what the recruitment process looks like and all of that. That being said, thank you all so much for listening to me, and hopefully we have some time for questions.
Thank you for that glimpse into your fascinating research. You're getting lots of claps and whatever people can do with their emojis. I'm going to monitor the chat, but let me just ask, so did you say you could tell us a little bit more about recruitment for what you're currently doing?
Yes, I can talk about that. We're trying various things. If you cannot tell, we're using multiple approaches. But I'll talk about some of the strategies that worked really well. So we recruited a young man who grew up in Chicago, who used to live the life, and by that I mean had a violence profile that sort of is similar to the young people we're working with. And he was our community champion. He also works with a male mentoring program, and he advised us very well. He and his organization, the Urban Male Network, advised us on recruitment, how to recruit, how much to pay. I mean, I used to be in Missouri. When I did research there, $25 seemed to go a long way. That was not the case here in Chicago. So some of those feedback, he helped sort of chaperone how we did our research. And like I said, there's a large amount of distrust, even of researchers. And every time I mentioned his name, they opened up a little bit more. They were a little bit more receptive. That helped. We also tried social media, which has been helpful, although I should say when you say Black youth or Black young males, you should expect people from all over the world registering for the study, which is what we had. And so we had to figure out ways to fine tune that, specifically recruiting from America. Our social media ads also were targeted to specific zip codes here in Chicago and specific demographics here in Chicago. So those are some of the strategies that help. And of course, word of mouth has been really helpful too.
So you answered another one of my questions, was sort of the role of peer mentors and trusted other young Black youth.
Yes, we couldn't do it. You can tell I have an accent. I've been in the US for 10 years. And my experiences of violence are quite different from what the young men in Chicago are going through. And so even though I can relate, it just made sense to make sure that they were very comfortable talking to us. Of course, in our interviews, we try to avoid having them talk about their own personal experiences of violence. We kind of keep it at the royal you. And so they explain based on their feedback and opinion, and that process seemed to help a lot. We did get waiver of parental consent up until a few days ago. That has changed, and now we need to get parental consent. That might significantly affect people we can recruit and retain. But of course, these are very sensitive topics, and it makes complete sense to include parental consent at this point, especially as we approach clinical trials.
Yeah, I'm monitoring the chat. I don't see anything unless I'm missing something, so I'm still looking. And so currently, are you unless I missed it, are you recruiting for any current studies?
Yes. One strategy that we found worked was we didn't want to go recruit new participants for every single phase of the study. And so we have what we're calling our sampling frame. We have a little bit over 300 young men in that sample, and we reach out to them first before we, look outside to recruit participants. And so that strategy has really helped. Some of the drawbacks of that is, people have moved on. This adolescent, they're very busy. I think the assumption is that all they do is school. Some of them are very, very busy, even with schoolwork. Some of them age out of our sample too as well. So that's something we cannot keep track of. But hopefully in the future we'll do a better job at that. But that sampling frame is where we go to first.
Mm-hmm. And so if we have, I'm just thinking of my patient population. I just asked a 21-year-old what he was going to do for his birthday, and he said apply for his FOID card. So a lot of our young men are exactly the folks you're talking about. So I was just thinking about interventions and tools for them. And so is there an intersection for these boys and what you're doing, clinically or research wise?
Yes, we're still recruiting. Maybe I should have put that QR code on the screen.
Oh,
Just
okay.
takes them directly to the red cap. That's not what we have here. I think this goes to our lab or something like that. But we still recruit to that sample. We also, are trying to engage these young men with, the youth advisory board and, the boot camps and those kind of things outside of the research itself. But to answer your question, yes, we still are recruiting.
Oh, great. I see, I'm really bad at this. I see my colleague Ruchi Fitzgerald has her hand up, raised hand. Let me see if I can unmute you, Ruchi. I'm trying to unmute you. Can you, hi Ruchi, I'm so glad you're on this. Can you, I don't know if you're in town or listening, Ruchi. Can you type your question? I can, okay, Ruchi. So Ruchi's a colleague of mine, works with the same population. I think we're waiting for, she's gonna type her question in the chat, and I'm so glad she has a question. Or you can text it to me, Ruchi. Stand by.
It must have been based on something I just said. And
Well, her population similarly, she works at West Suburban Medical Center right in the heart of our Austin community.
okay.
Let's see. Because I am unable, Amy, I don't know if you can unmute Dr. Fitzgerald. Here we go. My question is about your thoughts on prevention, specifically about violence prevention efforts and I don't know if you can see the question.
I can.
Okay, substance use sort of prevention efforts and movements that would include more harm reduction based efforts rather than focusing on fully preventing initiation SUD in this population.
Thank you, Dr. Fitzgerald, for your question. It is hard to ask in a chat. Harm reduction is, of course, we don't suggest harm reduction, for gun violence. The acceptance and commitment therapy, I don't think there's anywhere, in terms of how we're using it. We're adapting it from a violence prevention intervention. So we're figuring our way out in terms of our substance use component. So where we advocate harm reduction, of course, with in our module, the module focused on substance use, we don't do the same for. I agree. Yes, the death rates are extremely high, and of course, early onset of substance use, any substance use, often predicts, progression to substance use disorders, especially for Black and brown populations. So we're hammering on the harm reduction. To be honest with you, this is focused on a primary and secondary prevention level. I don't know what we do with the participant who has a substance use disorder in general, besides recommending them to a service in the community. But in this case, yes, harm reduction is one of the lenses with which we use to structure the substance use module. And Dr. Fitzgerald, if you want, I could show you what that module looks like specifically. And our modules are, they're not text-based only. We're combining multimedia. So we have, GIFs or GIFs, however you call them. We have videos that link out to reputable websites like the CDC. So 2-minute videos outside of the CDC if they do leave the app. We're using multiple strategies to deliver this intervention. It is hard to do, I'll be honest with you, in a micro learning module. They don't want to be reminded of school. They don't want to do a lot of reading. And so we're trying to make it a little bit interactive without making it entirely gamified, which is something they've told us they do not want. This is a serious issue to them. I don't know if I answered your question, but I'd love to talk a little bit more about the harm reduction angle for substance use, not for gun violence, though.
Well, here's what's going to happen, Dr. Emezue, because I know we're running out of time, but now that we found you, you'll never be rid of us. Because speaking for the addiction medicine team, this is a gold mine for us finding you. So as we were talking about offline before we hopped on, you had wanted to make some connection, and so the connection has been made. So I think we all look forward to chatting with you further. And it's 1 o'clock. So on behalf of all the listeners and people who will watch this at a later time, thank you so much for sharing your work and your thoughts and some of these interventions. It's really thrilling. Thanks again.
Thank you. And my 18-month-old slept through the 1 hour, so I'm happy.
Yeah.
All right. Thank you all so much, and talk soon.
Thanks again.